Or do you want to do that ahead of time? Do that ahead of time and then do it again when Stefanie asks you to do it. I guess that would be.
Okay, everybody's in now. Let's.
Yeah. Hi, everyone. Hi. Can everybody hear me okay? Give a thumbs up. Yes? Awesome. Fantastic. Welcome. So welcome to our telebriefing today. I'm Stefanie Murray. I'm with the Center for Cooperative Media, and you are here for a telebriefing on the coronavirus crisis with two New Jersey public health experts who happen to both be professors here at Montclair State University. So as I said, I'm Stefanie Murray with the Center for Cooperative Media. We are a grant-funded program based at the School of Communication and Media at Montclair State. And part of our mission is to help support local journalists throughout our state. That includes organizations large and small, freelancers, ethnic, community, and immigrant media as well. And today's telebriefing is part of an effort on our behalf to better connect different local news providers across our state with experts so that you can tell stories in your community as best as you possibly can about what's happening with the coronavirus. So with that, I'm going to throw it over to Joe Amditis, who will talk about the technical details of how the webinar will work today, and then Oni Advincula, who will talk about the program.
Thank you, Stefanie. And hello, everyone. As you may have noticed already, you aren't able to unmute yourself for this call. We have a couple of different measures in place that I'll explain right now to make sure that this is a good experience for everyone, that everyone gets a chance to speak, and that our experts have an opportunity to answer the questions that are posed to them in a reasonable and orderly fashion. And so the first thing, like I said, you'll notice that you are muted and you cannot unmute yourself momentarily. I will have to do that. With that in mind, what we'll do, if you do have a question throughout, and if you've seen the agenda, you know this is just going to be a very brief introductions from both of our experts, and then we'll go to questions as quickly as possible. When we get to that point, though, and along the way, you're welcome to drop questions in the chat. All of our panelists will be able to see them, and they will be able to prep or answer them in real time. And if you'd like to ask your question out loud, or if maybe you can't find the right words to type it, you just say, you can just indicate that in the chat, and I will unmute you individually when we call on you. I don't see anyone on the phone at the moment, so we won't have to worry too much about that, but I believe we may have a few people calling in. We'll try to make space to acknowledge them when we get to that, because unfortunately the features available to phone users don't allow them to indicate visually or with chat that they'd like to participate. So we'll have to make sure we defer to them at some point. That being said, I recognize a lot of friendly faces here. Thank you so much for coming. We are recording this, so if at any point you would like, I don't think any of this is going to be off the record, so I don't know if but we could stop the recording, I guess, if you'd like. Just let me know and we'll pause it and move forward if necessary. Otherwise, hang tight. We got a great little session for you here, and I'll throw it to Oni to introduce our panelists.
Good afternoon, everybody. My name is Oni Advincula. I am the media coordinator for the Center for Cooperative Media at Montclair State University, and I will be your moderator for today's event. Again, thank you for your attendance and welcome to the media teleconference on the impact of the coronavirus on ethnic and immigrant communities in New Jersey. Without further introduction, we will hear first from our first speaker, who is Dr. Stefanie Silvera. You have all the complete bios of the speakers, but Dr. Silvera is an epidemiologist and a professor in the Department of Public Health at Montclair State University. Dr. Silvera, please take the floor.
Great. Hi, everybody. Good to see you all. As Oni mentioned, I am trained as an epidemiologist, and I have been teaching at Montclair State for about 14 years now. And a lot of my work, one of the reasons that I'm really excited to be here, focuses on racial and ethnic health disparities. And we're starting to see a lot of conversations about racial and ethnic health disparities as they relate back to COVID. So I'm going to touch on that. But first, I wanted to just make sure everybody had a lay of the land in terms of what's happening now with the data. So the most recent data in terms of the state level data was released yesterday, at which point New Jersey had just over 75,000 positive cases and 3,158 deaths. If we're looking at that in terms of incidence, which is the number of new cases out of the total population in each state, that places New Jersey second in terms of new cases, only behind New York. New York is number one in the number in terms of incidence of new cases. We're currently also 15th in terms of COVID-19 patients who've been hospitalized, with about 11% of New Jersey cases requiring hospitalization. Currently, we have just over 8,000, so we're at about 8,224 patients who are hospitalized with COVID, of which 2,014 are in intensive care units and 1,645 are on ventilators. And those are really important numbers when we talk about this idea of flattening the curve, right? The point of flattening the curve isn't that necessarily that fewer people get sick, though that's obviously the goal. It's that fewer people get sick at one time. And so making sure that we have the hospital capacity to deal with people who need those beds. Another rate that epidemiologists are interested in, and you may likely have heard of, is the case fatality rate, which looks at how many people have died out of the number of people who've tested positive. And for that, we're ranking currently as 13th highest. Right now, our case fatality rate is about 4.7%, meaning of everybody who's been diagnosed, just under 5% die from this virus. The caveat to that is that our calculate a meaningful case fatality rate is really dependent on how robust our testing is. So for example, right now in New Jersey, we know that asymptomatic individuals are not being tested, meaning that we're only testing people who have symptoms and who meet very specific criteria of what those symptoms are. And they're typically people with more severe symptoms, and we'll talk about what some of the other challenges with testing are in a bit. But I think a better metric that we could be looking at is whether or not the number of deaths are increasing or decreasing. And at this point, at least in New Jersey, we are still on the acceleration phase of the curve, meaning those numbers are still going up. Within New Jersey at the county level, while Bergen County does have the most cases overall, followed by Hudson and Essex, again, when you take into account the size of the population to get the incidence rate, those numbers switch a little bit. And so right now, in terms of incidence, Passaic County actually has the highest incidence, followed by Union and Hudson counties. And Cumberland, Cape May, and Salem counties have the fewest in terms of both the overall number of cases and their incidence rates. In terms of deaths, Bergen County has the highest number at about 668, followed by Essex with 642, and then Hudson at, I think it's 656, I'll double check that. Unfortunately, municipal level data is much more challenging for those of us who don't work directly for the state, because those are not necessarily released. It really depends on the county and whether they're not going to, they decide to release them. What I can say is Jersey City, for example, has one of the highest caseloads. They've had just over 3,000 cases. Patterson is about 2,700 cases, compared to a city like Fort Lee that's only reported 188. And of course, these numbers don't tell us how many people from those municipalities have been tested. So they're really limited in what they can tell us in terms of how spread the virus is in each of those cities. One of the other issues that's been discussed more and more is whether or not there are racial differences in the number of cases or the number of deaths. We have to be really careful when we're talking about that, because right now we have very little data in terms of race. So we only have race data for about 21% of all of the cases in New Jersey. And so we can look at other states and what they've been doing and the disparities that they found. But right now we need a lot more data. We need to start collecting data on race. But when we do, I want to caution, I think there tends to be a rush when we discuss health disparities in general to try to attribute those differences to individual or community behavior patterns alone. And based on the work that I've been doing for a number of years looking at racial and ethnic disparities, I would hypothesize that what we're seeing is really an exacerbation of underlying health inequities that stem from policies that have put people of color at greater risk for illness and death in general. And when you look historically at things like access to housing, access to education, access to employment, and so on, you do see that there's some pretty stark racial divides. And those divides have led to some populations being concentrated in lower wage, but now considered essential jobs. And that means that those groups are at greater risk for exposure while also being more likely to live in densely populated housing units while simultaneously having less access to affordable health care. I know that there is a bill, I'm not sure if it's been signed by the governor yet, that would require hospitals to report demographic data, including things like age and ethnicity, gender, and race for coronavirus patients, whether they tested positive, died, sought treatment, or admitted. But again, those are going to be limited by people who feel that they can access healthcare by presenting at a hospital or presenting to different testing sites. And speaking of testing, for New Jersey right now, we're testing about 15 for every 1,000 people in the state. So that puts us about 9th in the nation. Right now, out of every 1,000 people in New York, they're testing about 25 people, which also is not good, right? So we are still very, very behind in the terms of testing. And so we don't really have a good sense also of who has access to the testing, right? So right now, like I said, we have less than 2% of New Jersey's population being tested, compared to a place like, say, Arkansas, where it's 0.3% of their population. But I think that most epidemiologists and other public health professionals agree we need more robust testing. And I want to note that most of the testing sites throughout the state are drive-up sites, which require access to a car. And that creates some significant barrier for our lower income individuals. The other places that provide testing are private physicians' offices and hospitals, which many lower income individuals might not access out of concerns for affordability or a lack of having health insurance or affordable health insurance that they can use. And I think those are really, in terms of where we are in the landscape of understanding the nature of this disease and how it's being spread and where it's being spread, the answer is that we still have a lot to learn. And I think that in terms of the media requests that I've been getting, it has been these questions of who's sick, where are we on the curve, when can we be done with all of this? And I think the answer to those questions are we cannot stop our social distancing practices until we have a better sense of how easily this disease is being spread and in which communities, and then how can we make sure that those communities have access to the resources that they need. The other side of can we be done is this idea of immunity and vaccines. So right now there are over 115 vaccine candidates across the world. 78% of them have been confirmed as active, where they're actually doing some level of testing. And then that drops down to about 8, which are in the preclinical phase, and 5 of those are in the most advanced candidates in terms of being moved into clinical development and testing. There are a lot of other people who have talked about different tests that they want to do, but we're not there yet. And so we're still several months. We're quite far from having a vaccine at this point. But we are moving ahead with research on blood tests to see if we can identify individuals who have some level of immunity. And again, those are just getting started. So we're still pretty early in this pandemic in terms of understanding the course of what it's going to look like long term. I don't think that we have a lot of really good answers yet. And the challenge of doing this type of science is it takes time, which is something I feel like a lot of us don't feel like we have. We want to get back to our lives. But I think we're, as I've mentioned in a previous media discussion, which is I think we need to start getting ourselves ready to recognize that this is going to be longer than just, oh, it's going to be 2 more weeks. This is going to change the way we act and in public, I think, for a very long time.
Thank you. Dr. Liu, do you want to introduce yourself and tell us a little bit about your work? And then we already are getting questions coming in, so I'm excited to get to that as soon as we can.
Joe?
Sure, Joe. So my name is Zayan Liu. I am an assistant professor at Montclair, and I just started this in 2019, in fall 2019. Previously, I was with the New York City Department of Health and Mental Hygiene, working with various projects there. So my area of expertise is really racial disparities, but really as it applies to healthcare access, hospitalizations, and emergency department use. I am also primarily interested in ethnic and immigrant communities in terms of their healthcare needs and the unique challenges and barriers that are associated with different communities of color. So I like to talk about several barriers and challenges that we are seeing with ethnic and immigrant communities in New Jersey that are facing COVID-19. One of the things I really want to emphasize is that is the barrier of language access, even for those who manage to get access to hospitals or access to the emergency departments for COVID-19 medical care. We know that even in the best of times, language barriers is a huge problem and is associated with worse healthcare outcomes. We also know that even though in the best of times, hospitals are required to provide interpreter services, we know in a crisis like COVID-19, that is not necessarily going to be provided in a timely manner so that the best quality care can be provided to different patients. So we also know that many immigrants use relatives as informal translators, but a lot of hospitals are not allowing guests to actually come in with patients. So I really think it's important for ethnic and immigrant communities to be prepared, have easily accessible written documents about their health conditions, medications that they might be on, a relative or friend's phone number to call. So have a plan in place to understand any of the doctor's instructions from the hospital, as well as a plan in place so that they can be able to provide that information as quickly as possible once they're able to be inside and access healthcare. So again, language access is a huge barrier for many ethnic and immigrant communities. And I think while this is a larger structural problem that we need to address long-term, in the immediate crisis, we need to be able to address it within your families and within individuals to have this plan in place. Another thing that is something that I've been talking about and I have done some previous research on is the mental health challenges associated with COVID-19. So COVID-19 is a traumatic event because entire communities are impacted by COVID-19, regardless of whether you are individually sick or whether you are just living through this chaotic time. This is what we call a collective trauma. Collective traumas often leads to higher mental health risks. And this is especially important for ethnic and immigrant communities to know and recognize signs of mental health problems and to seek help. We know that we've seen previous collective traumatic events like 9/11 and the Great Recession lead to higher mental health risks, even in ethnic and immigrant communities. So it's especially important now to recognize COVID-19 as a similar collective traumatic event and to seek help as needed. In New Jersey, that's through the toll-free number 1-866-202-HELP 4357. Finally, I'd like to talk about some other issues such as immigration status. Undocumented immigrants might not feel that they can access care because of fear. So it is totally understandable that undocumented immigrants are concerned given the current political federal climate. But for immigrants in New Jersey, we want to again stress the message that's been coming from Governor Murphy. Governor Murphy has repeatedly said he is committed that testing for COVID-19 related services will not be of any charge regardless of immigration status or whether or not you have health insurance. And seeking healthcare related care for COVID-19 will not be negatively affected by anyone's immigration status or health insurance status. So again, the emphasis is that immigration status should not impede any individual's quest to seek care or to get a better idea of what access to services that they should be able to access. This kind of leads us to what we've been talking about in terms of testing access. We know that in New Jersey, at community testing sites, the state is asking people to bring their health insurance cards so that health insurance companies can pay for the test. But again, even within these community testing sites, if you don't have health insurance, you will not be turned away. It's really important for people to understand, especially in ethnic and immigrant communities, that lack of health insurance should not be a reason at all for people to not seek testing at the community testing sites. Dr. Silvera, was there anything you wanted to add with the testing access?
I'm just unmuting myself. Sorry, it took me a minute. I would say that in terms of the testing access, right now in New Jersey for the drive-up sites, Governor Murphy has made it clear that they are asking people to show their health insurance card if they have it, so that if you do have insurance, they can bill them, but that nobody will be turned away if you don't have health insurance. And they are not asking about immigration status at those drive-up testing sites. So the barrier would be the driving up part, but your immigration status and lack of health insurance, at least in New Jersey, should not be the reason to not get tested. And so that, that information is on the New Jersey State website for their COVID-19 response. And I think that that's really important in terms of a message to get out, because we don't want people who are sick and need care to not seek it out.
Exactly. I think finally, one of the things I like to address is a question that I've been getting a lot from my own immigrant family circles. And it's the idea of BCG vaccine and whether or not that conveys any immunity or help in any way with COVID-19. So as many of you might know, BCG is a vaccine specifically for tuberculosis, and some immigrants from other countries may have received the BCG when they were younger. This is a vaccine for tuberculosis that has been offered and is commonly found in Africa, Asia, and South America. So I want to emphasize that currently there's no proof that BCG protects against COVID-19. There's several scientific studies right now that are being done so we can understand more about this. But again, I do want to emphasize, especially for immigrants that might have received this BCG as a child and think that this might help them in any way with COVID-19, that there's no scientific proof currently that BCG protects against COVID-19. So with that, I'll turn it back to Joe and to Oni to moderate any questions that you might have.
Okay, Oni, do you want to go ahead and start down the list of the comments, and then we'll get to the folks where we need to unmute them and have them ask?
Sure. Dr. Silvera, before we proceed to the Q&A, our health experts always say that communities of color have been disproportionately impacted by COVID-19 because of pre-existing conditions. But when we talk to the members of these communities, they say that cramped dwellings, high density and low income neighborhoods, inaccessibility to testing and proper health care are some of the factors that significantly affect them, yet we don't often hear this in the media. Can you briefly talk a little bit about that?
Absolutely, and I agree that those are the issues that aren't being talked about. I would also say that those same issues in terms of access to housing, access to healthy foods, access to clean air, access to areas for physical activity and recreation spaces are also the same things that underlie comorbidities. So when they talk about having underlying health issues, those are clustered in certain populations for a reason, and those are structurally mediated, right? And so they've been referred to as sort of these structural inequalities or racist policies, as some people have called them, that really concentrate health inequalities in certain communities. And then we layer on top of that a virus that does spread through crowded housing dwellings and amongst people who don't have a choice. They don't get to work from home. Right? So the whole stay at home order also implies that people, it's shelter in place, which only works if you have a place to shelter. So, we talk about low income communities, but when we're talking even at the most extreme about homeless populations who are most at risk. But none of that is accidental. So these clustering of health outcomes and adverse health outcomes that lead us to have these comorbidities that then put those populations at greater risk for death from COVID are all part of a continuum of health inequalities that we see. And so I get frustrated when you hear on the news, and I've done a few of these now, so you get 30 to 40 seconds to answer a question, and that's not enough time to really delve into all of the nuances of how we got where we got and why some populations are at greater risk for dying. And that has to do with, previous socioeconomic status, et cetera. We've known for a very long time that your zip code is the best predictor of your life expectancy. And it shouldn't be, but it is. And we're seeing that more and more now, which is why I know a lot of people, epidemiologists and people in the media, are asking for even zip code level data on who's being diagnosed and who's dying from this disease, so that we can better understand why, right? So we can't solve a problem that we don't know exists. And this is where, as an epidemiologist, I want to know more. I want to know about the gender and the socioeconomic and the racial and all of those other factors, but not because I think that those are the biological reasons for why people are more likely to die, but because I think those are all markers of something deeper in terms of the policy that leads people to die in this country. COVID is not changing who's dying. It's highlighting it in a way that I think is making it more difficult for us to ignore.
Thank you. Our reporters are so anxious now to ask their questions. So we will now proceed to our Q&A. And our first question comes from Rong Xiao King of Xingqiao Daily. Rong?
Let me just make sure I got her here muted. Is she? There we go.
Yeah.
Go ahead, Rong. You're good.
Can you hear me now? Okay. Hi. Sorry, I have to turn off my video because the internet doesn't work very well. But my question is, I know there's not specific New Jersey data comes out, but in New York, we do have this data about death, coronavirus deaths, which shows that in New York City, Asians makes the smallest percentage, only 7%, given despite Asians' population takes 14% of the entire population of the city. But as Dr. Silvera mentioned just now, it may not be, because people here in New York thought this is because that we did precautions earlier. We put masks, we did all the things right. But when you look at the state, the New York State, except for New York City, that data shows that Asians make 4% of the deaths, which is equal to their proportion of the entire population, while white people's death proportion is less than what they make in the entire population. So I'm thinking New Jersey's situation might be similar to upstate New York. Can you guys give us some about your observations or your understanding of this issue, that are the precautions that Asians take really make a difference, or is because of the social economy or all that other factors?
So I'll jump in. I know that in New Jersey, again, our race and ethnic data are not great. We have only about a fifth of racial and ethnic data on everybody who's been diagnosed. But of those people, I think it's about 5% who've tested positive identify as Asian, which is a little bit higher, actually, I think, than what our population. I haven't looked at the census specifically for New Jersey data recently. And I think that we have to be really careful of ascribing who gets this disease to any one thing. So obviously, some of it is how well people are able to shelter in place, whether they have access to masks, whether they're using them properly, which is a really big problem that I've seen on the 1 or 2 times I've ventured out. But in general, there's good data to show that people typically don't use masks properly. In addition, people using gloves and not using that properly. So I think that while I understand the urge to try to understand this, we are still so early in this epidemic that understanding the sort of interaction between structural factors and individual level behaviors and sort of cultural factors of who behaves in what way are still being teased apart. I'm not sure that we're there yet, and I'm not sure that we can tease apart individual behaviors from things like socioeconomic status, because socioeconomic status drives how we are able to behave in a lot of ways. Dr. Liu, I don't know if you want to jump in or add anything to that.
I totally agree with you, Dr. Silvera. I think it's too early to really make any definitive claims about why, at least at this point, we're seeing the proportion that we are. I will say, at least in New York, there are certain areas where a lot of Asians that might be of lower SES, such as Sunset Park, parts of Brooklyn, parts of Queens, or lower Jackson Heights, where there's a huge ethnic Asian population, and it's the epicenter of cases in New York City. So again, I think it's really, you need to be really careful about making these kind of, we need to be really careful about making overall claims, because SES is so related to access and risk within COVID-19. I also think Asians really cover a huge, a large group of ethnicities and cultural identification. So again, I think we just need to be a little careful until we have more complete data to best understand what we're starting to see.
Thank you. Our next question comes from Mohsin Zahir of the Pakistani newspaper. Mohsin?
Yes, I have one question for Dr. Silvera and one for Dr. Liu. For Dr. Silvera, my question is, what do you think, how much racial and ethnic disparities matter when it comes to coronavirus outbreak in New Jersey? And for Dr. Liu, you said that for undocumented immigrants, testing in New Jersey is free. My question is, what about undocumented immigrants who are COVID-19 positive, admitted in the hospital, and have no health insurance? Would they are gonna receive the hospital bills if they recovered and go back homes?
Okay, so I'll jump in first to say that, you know, right now, again, I just want to keep giving the same caveat. I apologize for that, which is that we don't know very much about what the current racial and ethnic differences are. So we know this based on the self-reported data that we currently have, which comes primarily from hospital cases, because when somebody's in the hospital, they're able to get race data much quicker, and it's much more accessible than through these drive-through tests at those testing sites. And I'm not sure how much of a focus there was on collecting this data initially, right? It was more about just finding cases. What I can say is about a quarter of all cases that we have racial data for in New Jersey are individuals who identify as Black or African American. The number's a little bit higher for people who identify as Hispanic, that's 26.7%. And about 38.7% are people who identify as white. I think knowing what the demographic breakdown in New Jersey is, that tells you that there are disparities in terms of Hispanics being more likely to be diagnosed, and individuals who are Black who make up a higher proportion of the cases. I suspect that we'll continue to see that sort of disparity, those differences in the numbers, with certain racial and ethnic groups being overrepresented in the data. If for no other reason, then that's what we tend to see in the data in general, but also that in other states and in other cities that are collecting this data in a more robust manner, that's exactly what we're seeing play out in places like New Orleans, in Detroit. And the other thing that I have looked at and I've noticed in my own home county is that if you look at within New Jersey, within Passaic County, for example, I can line up the incidence rates and they match the top 4 municipalities for incidence in Passaic County are also the 4 that have the lowest median income, and they are also the 4 that have the highest percentage of individuals who identify as Black or African American. So the fact that I can predict incidence within Passaic County based on the racial and ethnic makeup of that municipality is really telling. And I think that that's something that we're going to need to really start addressing and thinking about in a pretty holistic fashion, in ways that we, I think, have been very loath to discuss previously in general.
Thank you. Our next question is from Clybel Marcano of Reporte Hispano.
Hi, everybody. One question. Yesterday, the White House present a different phase where they hope to open the economy in the country. So what do you think, doctor? Do you think this makes sense, the phase that they show, or something that is not real?
So I am not an economist, so I will say that I think that is a question that's really for economists to kind of talk about, and urban planners to talk about in more details. And I believe that that's something that should only be opened up if there are certain key criteria in terms of handling the public health crisis has been met. WHO actually has 6 really clear conditions of when any area, any country, state, or locality should meet before they even consider opening up. And I think those 6 conditions outlined by WHO are really clear and are really milestones that we have not, and we're not even close to meeting in New Jersey or in the US overall.
Yeah, and I would jump in to just piggyback on that, which is to say that both right now we're seeing in other countries, places that have tried to open up before they had enough protections in place in terms of the public's health. So certain areas in Japan, for example, are already experiencing a pretty significant second peak, even though they did a really good job in responding to the initial risk. And when you look historically at things like the 1918 flu pandemic, you see that cities that left the interventions, these distancing interventions in place longer, overall did better. But places like Denver, for example, sort of took away all of the distancing measures and really reopened. And their second peak was much higher than their first peak. And so rushing to return to normal, again, I'm also not an economist. And so I get that there's a whole different aspect from the economy perspective, but from a public health perspective, opening too soon really leaves us at risk of having a much larger second peak, which would put a lot of pressure on our already taxed healthcare workers, our healthcare system. And I guess my one sort of economic pushback would be, if a lot of people are sick, they're not in the business place anyway. So it has an impact on people who are out because they're sick, or people who are attempting to go to work when they're sick, and then further spreading this very infectious disease.
We have a lot of questions and we want to accommodate everyone. The next question is coming from Kimi Wei.
Hi. My question, I have a question about undocumented immigrants. Like, where are they supposed to go to get tested? Like, for the general public, I live near the Berkeley County Center, and they only take 400 people a day. And often they're limiting the testing population to only people that are in the medical profession, that are frontline workers. Like, it's not so easy to get to that location either. And the Homedale location, I think, is less accessible, except if you have a car. And at Bergen Community College, I don't even know if they're allowing walk-ups. So if a lot of undocumented immigrants don't have cars, so how would they get to a testing center anyway? Or are there other places where they can get tested?
Thank you.
Do you want me to take that, Sam, or? Okay. So I think your point is actually very well taken. So most of the testing sites that are open to the general public are drive-up testing. And I believe that most of them are not taking walk-ups, right? So they want people in a car. You're allowed to open your window. I believe it's 1/4 of an inch to exchange information. You have to face forward when they're doing the testing. So there are some very strict protocols. And yes, I think that priority is often being given. I can't confirm or deny that to the medical professionals. The other places that are doing tests are a lot of these private urgent care facilities have tests available, or hospitals. So again, when you ask about how accessible is this for immigrant populations, they're not very accessible, unfortunately. And I think that that's a really, again, testing has been a problem. Testing has been a problem from day one, and not having a sufficient amount of tests. Even when we do have the test, like you said, there's only a limited number that can be done per day. People are lining up the night before in their cars and sleeping in their cars. And these are people who are symptomatic. So, I'm not in charge of it, so I don't have a solution. I wish I did. But unfortunately, I think what that means is that people who have less access to a car are less likely to be tested. And yeah, I know through the work that I've done with other health outcomes that very often one of the biggest barriers to accessing healthcare is whether or not you have a car.
All right.
Sorry.
Go ahead. No, go ahead.
Please.
I was just going to say we have more questions, so let's get to them. Oni, do you want to? Who's up next?
Yeah, we have 4 questions in the pipeline. The next one is coming from Don Tagala of ABS-CBN News.
Okay, Don, let me just find you on the list here and unmute you. There we go. And you should be good. Go ahead, ask away.
Can you hear me?
Yes, we can.
So this question is related to the one about reopening. So what if the US is reopened as promised by Trump earlier than usual, or earlier than what's supposed to be opened or reopened? What should people keep in mind as they go about their lives at work? How do you visualize this scenario? Do we have to be in full PPE gear at work or in public, knowing that there'll be a lot of asymptomatic COVID positives walking around? So what's your biggest, how do you visualize this scenario if it indeed was reopened?
I think that that's a really interesting question. And again, I just want to reiterate that regardless of what the president is saying, this is really going to have to be a regional and state decision. Even as President Trump said, this is going to, when and how we reopen is really going to have to be led by governors' actions. And I think what you really are going to see is different phases of reopening. And what those phases mean, we really have to think through that. And it might mean different things for different areas. How California and how Washington experienced this COVID-19 crisis has been really different from how New York and New Jersey has. Again, similar to what Dr. Silvera has said, we need things like ready access to testing for everyone as one of the primary conditions before we should be thinking about reopening. And again, when we talk about reopening, we really have to think about it in phases, and what each of these phases are really going to have to be evaluated. And we have to make sure that the system, not just the healthcare system, but the economic system and the social system is ready to handle any new stresses on it. So it's not a straightforward answer because I don't think there's a one size fit all. And I think I just want to reiterate that we really want to be careful about, again, that push to reopen might be for economic reasons, but this is first and foremost a public health crisis. And we really need to address the public health side of it before we even worry about the economy. Because if we can't address the public health side of it, the economy will not be able to bounce back no matter what. So again, I want to again emphasize that this is a public health crisis, and we really need to look at the facts and figures associated with that to plan or even think about reopening.
Thank you. Our next question will be from Carlos Avila of the Nubian News.
Go ahead, Carlos, you're good. Oh, actually, we can't hear you. It looks like maybe your mic is not connected, or maybe it's extra muted. Now you're muted, and now, yeah, now you're muted. But why don't you? Unfortunately, I don't think we're having a little audio issues with you. Can you go ahead and type your question, and then we'll make sure it gets asked. You're muted. I can't hear what you're saying.
We'll come back to you, Carlos. Let's go to Kevin McNear of the New Jersey Urban News.
Okay. Kevin, I'm looking for you here.
McNear,
yeah, I want to make sure if he's actually on. Is he on the phone? Maybe he's on the phone. McNear. Oh, what's the username?
Dominic McNear.
Oh, Dominic. I think you said Kevin McNear. I don't know why I heard Kevin. There we go. Go ahead. You're unmuted.
Hi. Yeah, because I'm Dominic Kevin McNear. That's why.
Oh, okay. Oh, okay.
Yeah, like F. Scott, D. Kevin. So hey, my question. I'm wondering if I'm teasing this out. I would really like to hear from the experts. I heard a lot of comparison between the Spanish flu in 1918 and looking at what happened and how it spread, and final evaluations of how they got through that. I'm wondering how valid that is in terms of comparison historically. I like to read the history, but I don't know, I haven't gone into it enough to know just how closely aligned we should be pressing this. I see some of my fellow journalists are doing so. I'm just wondering how that epidemic compares now in a quick fashion, just for illustrative purposes, when I'm talking to African Americans about fears about this virus.
So I can answer a little bit of that, in that obviously there's going to be differences. We know at the time of 1918 they thought it was a bacteria. It turns out it wasn't. It was a virus. So our scientific knowledge is better. Our access to medical masks are better. We have hospital systems and ventilators that we didn't have at the time. And the way that it is spread is going to be much different. What we saw in 1918 was that there were waves of epidemics across the country, starting on the East Coast. And as people traveled, it moved to the West. And you saw different peaks and different responses on really a city by city basis. So some cities, Boston basically stayed wide open. St. Louis put a lot of what they called the non-pharmaceutical interventions into place. Places like Garrison really literally barricaded the one road into town to try to block the virus from getting in, from limiting. So I think the big difference here is that we have global travel. You can look at flight patterns. People are still flying even today. And so global travel is going to change. We're not going to see these sort of clear waves of who gets sick and when. In terms of, looking at it from sort of a racial and ethnic perspective, I would say that it is the history of where our country came from that has led us to racial and ethnic disparities that have in some ways improved, but in a lot of ways have essentially stayed the same, and in some cases have even gotten worse. I do think that we can learn a lot from the history in terms of what not to do. So looking at, for example, Atlanta, which opened up soon and threw basically a parade because everybody was excited to be back open, and then were hammered with cases. And so I think that we can learn a lot from that history. And so I think that's why we're drawing from that. Obviously, when we look at the data, most of the data from the 1918 came from historians who, I have a colleague, somebody I know, who did this work, and they literally traveled around the country pulling newspaper data, right, media reports. But I think it's very safe to say that in 1918, racism was probably even more severe and more significant. And so the reporting is obviously going to be biased towards who did the reporting and who they were reporting on. So I think we do need to be a little bit careful there and applying our understanding of the historical data.
Thank you very much. We have a question from Norman. Are you still there? Norman Scherzer.
Yes.
Please go ahead.
Yep, you're good.
First, I'm glad to meet some of the speakers. I've tried to send you some emails. My name is Norman Scherzer. I live in Little Falls. I'm your neighbor. I worked for the Centers for Disease Control for 25 years. I was the Assistant Commissioner of Health of the city of New York. And what I'm concerned about and looking for comments on is I can't seem to get information from the limited amount of contact tracing that's going on. So even questions that come up that say we have so many cases fail to distinguish between the date the test was taken and the date of the report. I'm working with a group of colleagues on a volunteer basis at CDC. Either now or later, I would love to get your input on, we're trying to put together a standard contact tracing format. And one of the reasons I was interested in this discussion is you're focusing on something that we're really not yet focusing on, and that is, should we be asking about the country of origin of the patient? Should we be asking about their ethnic status? Should we be asking about other types of things? But right now, I will tell you, I have spent many years in all kinds of outbreak control, including the swine flu and what have you, and I've never seen such a lack of information to go on. So I'm sorry for such a broad question, and hopefully some of your colleagues can reach out to me afterwards, because I would love to talk to you further about this.
Yeah, so I've been getting quite a few questions about contact tracing or the lack thereof. And this is a big, I would say it's been one of our weaknesses in doing the contact tracing, as well as the delay between the date that a test took place and the time that people are being notified about their positive or negative result, which is several days. And part of that is that for most, well, there's a few reasons. So they didn't open up to private labs until late in February. They did not, and even then, so Quest, for example, has said they're overwhelmed. They take hospital tests first, they get priority. And because of Quest in Teterborough's proximity to New York, they're getting overwhelmed with New York tests, even though we have a number of people trying to test in New Jersey. So the New Jersey tests are being sent out across the country. So there's significant delays. There's been very, very, very limited efforts for contact tracing, and those have varied. There's no federal response to contact tracing. So those are happening really at the local and often hyper local, or not happening at the local and hyper local level. So I think that's a problem. And so I think there's a lot of work that still needs to be done. And thank you for taking it on a volunteer way. I think that it's really important. I'd love to talk to you more about this after the meeting.
Sorry, go ahead, please.
Oh, no, I just wanted to add, I started my career doing contact tracing for tuberculosis. And I also did contact tracing for the measles outbreak that occurred just this past summer in New York City. So I totally agree with you that there just has not been enough focus on contact tracing. I do think because we're just at the next phase of the crisis and at the epidemic, so contact tracing, to try to institute it at this point, is really, might not be the most effective ways to flatten the curve, unfortunately, right now. But I do agree with you that contact tracing is so crucial. And for reopening, we need to have that plan in place before we, as one of the key components to think about when we reopen. So yeah, again, really important, and just we haven't seen this in this public health response.
Thank you. We can only accommodate 2 more questions, and one of them, question from Carlos Avila, and she sent a text message. Why do Latino and African American communities are in the high risk to getting COVID-19, and what the state is doing on this issue?
I don't know if Sam was going to talk or not. So I think, again, when we look at why are some people, first of all, I would caution in terms of, based on the data that we currently have, there are more cases in the Black and Latinx populations. The why for that may be related to issues regarding employment, so being more likely to be employed in low-wage jobs, which have now been deemed essential. So people working at grocery stores, working food delivery, et cetera. So those things that keep our economy moving, that keep our lives moving in a comfortable way, and yet are often underpaid and often don't have access to health insurance. But it's requiring those individuals to come into contact with more people and therefore be at greater risk for contracting the virus, I would say. I think, as Dr. Liu and I have said probably more times than everybody is comfortable with, we don't know at this point, right? So we can hypothesize about all the reasons. We can point to underlying structural inequalities that have led us to health disparities in a lot of ways, but I don't know that for this virus in particular, we know all that we need to know. And until we get better data, we won't know.
Thank you. There is a question that was texted, and then I'll give it to the last one would be coming from Kamau Kujigahalia of the Nubian News. But the question here is, immigrants are scared to show up at public hospitals because of the public charge rule that the Trump administration is hoping to enforce. If you are deemed a public charge, you won't be able to apply for a green card. What can you say about this?
I'm going to let Sam take this.
Sam?
So I want to be really careful about the information I'm giving out. To the best of my ability, I believe that ICE has said that they would not be prosecuting or looking for undocumented immigrants around healthcare facilities during the COVID-19 crisis unless there's extraordinary circumstances. What is extraordinary circumstances? What does that entail? They have not really gone into detail about that. So I can understand the fear. However, I think New Jersey really has and under Governor Murphy really has a commitment to providing healthcare, the best quality healthcare testing for COVID-19 and access, regardless of immigrant and or undocumentation status. So I know this might not be the most clear answer, but in many ways, I think there is this contradictory messages we've been hearing from the federal and from the local or state government. And I want to be able to recognize that and say, I understand that fear. But I do think there is a commitment on the local and state level to really provide COVID-19 testing and to kind of allay those fears for everyone. Because in the end of the day, we're all part of New Jersey.
Thank you. The last but not the least question would be coming from Kamau. Kamau, if you are still there.
I'm still here.
We can hear you. Go for it.
Okay. Number one, Trenton has testing right now, walk-up testing in the city, but it's secret. They won't disclose where they're going to be each day. Oh, there's 4 of them in 4 different places. And anyway, I talked to the people and I said, you know, this seems to be, you tell everybody else where the testing sites are, but when you come into Trenton, into a basically Black Latino population, everything becomes a secret all of a sudden. And so you're expecting trouble out of us where you're not expecting trouble out of any place else. Anyway, my thing is that, you know, we talk about, we don't talk about racism. I mean, racism as always is the reason that people are in the positions that they're in right now. And, you know, I'm concerned, my question is there an ombudsman in the hospitals that since visitors can't go in, family and friends can't go in and see how their people are doing? Is there somebody in there looking after the welfare of Black and brown people once they get to that hospital? Because racism is bad on the outside, and it has to be bad on the inside too. So, you know, we're concerned about that.
Can you address that briefly? Because we actually run out of time. If someone can address that really quickly.
Just tackle racism really quickly.
Real quickly. And I'm a professor. We don't tackle anything quickly. So what I would say is I just want to say that, yes, I hear you. I think that there are a lot of concerns. I don't work at a hospital. I can't answer the question of who's the person that is looking out for the needs of Black and brown folks. Typically the person they have social workers who are assigned to do this, and how versed are they in historical racism? I think that's going to depend on the hospital you're in, the state you're in, the city you're in, and the community that those people come from. But I think it's valid to be concerned about, racism in this country.
All right.
There you go. Thank you all. Thanks our presenters and media representatives. We truly appreciate all your participation today.
Yep.
We will send out the recording and transcript of this telebriefing. And Joe will have special announcements before we adjourn.
So yes, really quickly, I just wanted to let you all know, we just published this, but we just announced a couple of different things here. One is a freelance stipend or freelance grants that we have available to support journalists, independent journalists and reporters who are covering COVID-19 and the coronavirus pandemic in New Jersey. That also comes with there's an additional opportunity there for $250, up to $250 in equipment purchase funding. And also to let everyone know, the Diversity, Equity, Inclusion Travel Award Program that we launched in 2018 will continue for 2020. The award fund is dedicated to helping New Jersey journalists attend trainings, events, and conferences hosted by organizations that are working to address issues of racism and improve diversity, equity, and inclusion in media. And obviously, there's still a lot of events this year that are a virtual environment. We are certainly not encouraging you to travel at this moment or until it is safe. But there still will be registration and membership costs that are associated with many of these programs, and especially the ones that are hosted later in the year. If it's safe by then and in person, we still would love to be able to help you out with those costs. So you can find all that at centerforcooperativemedia.org. Down there at in the latest area, you'll see a little picture of a blue and pink camera, or I just posted the link in the chat. And I know you can't copy and paste out of this chat, and I'm trying to fix that. I don't know why that's the case, but rest assured that we will include this link, a link to the chat file, a link to the video recording, and an auto-generated transcript, which is synced to the audio from this call. So for those of you who need a transcription, this is a rough auto transcription that you can use. So all that will come in an email by the end of the day, for sure. Again, just wanted to thank everybody. And then one more thing, Stefanie, I know I'm missing something. I'm forgetting I opened the wrong draft file. So.
Yeah, thank you, Joe. Thank you, Oni. Dr. Silvera, Dr. Liu, thank you so much for your time. Joe and I and
amazing.
Oni texting each other in between, and we're like, we'd love to ask you questions for the next 2 hours. So we're very grateful for your time. Thank you so much.
Seriously, this is great.
Yeah, and so for any of our folks who want, so Dr. Silvera, Dr. Liu, you're welcome to leave. Anyone who wants to stay on, Joe and Oni and I are happy to. Thank you so much. Happy to answer questions and talk to you more about some of the funds that we have. So Joe mentioned that we just announced this afternoon